وبنشكر ايمن ده جاي لنا بعد اسبوع ان شاء الله راجع الاسم عندنا، وبنشكر اللجنه المنظمه مع الاستاذ الدكتور راشد، وبنشكرهم على المؤتمر الجميل المثمر ده المعلومات القيمه. والان مع الاستاذ الدكتوره بروفيسور جيهان شوقي ذا جازيل يونيفرسيتي فور empyema اوف جول بلادر. اتفضل.
بسم الله الرحمن الرحيم. في البداية بحب أشكر الأستاذ دكتور راشد لدعوتي للمشاركة في المؤتمر، وبشكر اللجنة المنظمة والشير بيرسون والحضور الكرام. I'll talk to my talk today is gallbladder empyema. Empyema of the gallbladder is the most severe form of acute cholecystitis, and is usually the result of progression of acute cholecystitis in background of bile stasis and cystic duct obstruction. It's considered a surgical emergency that required prompt treatment with antibiotic, urgent aspiration, or removal of the gallbladder to reduce the risk of septic shock. About the etiology of empyema of the gallbladder is associated with calculous cholecystitis, where there is an obstructed cystic duct and stasis of the bile. Stagnant bile in the gallbladder has superinfection with microorganisms that lead to suppuration in an acutely inflamed gallbladder. Hence, the gallbladder become filled with exudative material and very often frank pus. Rarely, empyema of the gallbladder may present in association with common bile duct stone or carcinoma of the gallbladder. Organisms frequently isolated include Clostridia, Bacteroids, Klebsiella, and Escherichia coli. Epidemiology. The occurrence of empyema of gallbladder occur in 5 to 50% of cases diagnosed to have acute cholecystitis. Is noted to be more morbid condition when occurring in older age groups or in immune compromised patient. Patient with increased risk of acute cholecystitis, such as those associated with diabetes, immune suppressant therapy, or hemagglutinopathies, have a higher chance of developing empyema of the gallbladder. The pathophysiology. Stagnant bile due to cystic duct obstruction in the background of gallstone disease can become infected. Severe infection is caused by pathogenic Escherichia coli, Klebsiella, Streptococcus faecalis, and anaerobes such as Bacteroids, Clostridia. Pus formation follows this infection, tightly filling the lumen of the gallbladder. In a tense and edematous gallbladder, necrosis of the wall and perforation may ensue to drainage if the drainage or removal of the gallbladder is not performed promptly. If not treated rapidly, the patient can develop generalized sepsis or gangrene of the gallbladder, resulting in perforation of the gallbladder. Rarely, a fistula between the gallbladder and duodenum can occur as a sequel of inadequate treated empyema. Untreated cases develop symptoms of localized sepsis due to microperforation or generalized sepsis due to macroperforation. History and examination. Patients with empyema of the gallbladder have symptoms similar to acute cholecystitis. Presenting symptoms and signs only tenderness in right upper quadrant with positive Murphy sign. This is the most common predominant presenting symptoms and sign. With worsening of the disease, patient develop fever, chills, rigors, and signs of systemic sepsis follows. Patient with immune compromised or diabetic may have more prolonged course with a few associated typical signs and symptoms as described above. If the gallbladder perforation has occurred, the patient may have tachycardia, fever, generalized sepsis, and chills, tenderness in right upper quadrant, and we can palpate the distended gallbladder. Investigations. A combination of clinical, radiological, and laboratory investigations. This is crucial to arrive the diagnosis of empyema of the gallbladder. About laboratory investigation, we do CPC for the patient. If persistent elevation of white blood cells and leukocytosis more than 15,000 per deciliter with left shift on differential despite appropriate antibiotic therapy is characteristic of empyema of the gallbladder. But this scenario also may occur in association with gangrenous cholecystitis and several other differential diagnoses. Other investigation is the liver function test. When the empyema arises from acute cholecystitis, liver function are within reference ranges, except in the case of Merizi syndrome, where the distended gallbladder breaks on a common hepatic or bile duct. In this case, we can find a mild elevation of alkaline phosphatase and bilirubin. Also, serial blood cultures are done for the patient to detect the organism, also to choose the specific antibiotic. About imaging, an ultrasound is the most commonly used radiological investigation in gallbladder disease. It's not diagnostic, but raises suspension of empyema if there is very edematous gallbladder with echogenic content in the gallbladder associated with gallstone. This picture of ultrasound showing gallbladder distension with a sludge inside. The sludge inside the gallbladder may arrange in layer or may be a sludge mass. Other investigation is CT scan. CT scan can be helpful when ultrasonogram is not contributory. CT scan may reveal an enlarged, distended edematous wall of the gallbladder, also pericholecystic collection. The other radiological investigation can be used as the MRI. A heavy T2 weighted sequence on MRI can help in differentiation of pus from sludge. Also, MRI show fluid level with a layering in purulent bile. As I said before, radiological finding alone may be insufficient for accurate diagnosis. Crucial diagnosis, clinical investigation, and laboratory. Good. What is the treatment and management of our patient? Empyema of the gallbladder is surgical emergency. Patient need good hydration, good antibiotic coverage, aspiration or removal of the gallbladder. Optimizing the patient for surgery as soon as possible. Early in the course of the disease, Good results are achieved with adjuvant administration of second generation cephalosporin. In more advanced cases associated with perforation or generalized sepsis, broad-spectrum antibiotic with piperacillin tazobactam is advised. Antibiotic coverage is modified according to culture result as soon as possible, and by culture result also we can detect the bacteria resistance in different hospitals. Although the conventional practice is to perform open cholecystectomy, and it's possible also achieve laparoscopic removal of the gallbladder by experienced surgeon. But there is a very high rate of conversion from laparoscopic cholecystectomy to open procedures because there is reduced visualization and distortion of anatomical structures or increased bleeding due to inflamed friable tissue. If our patient is too ill to do the surgical procedures, so we can perform decompression or cholecystostomy either by radiological or intraoperative by laparoscopic drainage of gallbladder. These initial drainage procedures often lead to dramatic improvement in the patient condition, which is then permit an elective cholecystectomy when the patient condition improves. Percutaneous cholecystostomy is done either transhepatic route or transperitoneal route. It's preferred to do transhepatic route. Cylinder method preferred than single-step catheterization using 8 French big-tail catheter. There is possible complications while doing this drainage as biliary leakage, biliary peritonitis, hemorrhage, bowel perforation, infection, or blockage or dislodgement of the drain. About the differential diagnosis of empyema is cholecystitis, gallstones, or biliary colic. The prognosis, if treated promptly, the outcome are good. However, the individual with advanced age or are immune compromised usually to have a worse outcome compared to healthy people. Post-operative rehabilitation care following surgery and removal of gallbladder, intravenous antibiotics are required until the fever subsides and white blood cells return to normal. Most patients are discharged home on antibiotic for 1 week. Again, don't forget this is a surgical emergency. Please take in mind any patient with acute cholecystitis not responding to treatment must search for empyema of gallbladder. Thank you.
شكرا دكتورة جيهان.